I think with diseases like CLL, we had kind of forgotten that we needed better therapies. Certainly looking at a drug like single-agent chlorambucil as initial therapy, where you don't get good depths of responses and therefore you don't get long durations of responses. But that's all we had. So we added drugs. We got our monoclonal antibodies, and they certainly added benefit. But still, for most patients, you eventually come to a point where you've exhausted reasonable treatment options, certainly options that you would have confidence that would be effective for a patient. Now, of course, it's all different. So now we have fundamentally different drugs that work by different mechanisms that are very well tolerated. And so, yes, we should focus on efficacy. Of course, tolerability is important in the equation, especially for our typical older patients. But these drugs are tolerable too. So what's wrong with giving a more effective drug? There's nothing wrong with that. What's wrong with giving a drug that's better tolerated? That sounds pretty good to me. And fortunately, we've demonstrated in trials that we can get dramatically improved efficacy in many settings compared to our standard therapies, whether it's progression-free survival, in some cases overall survival, and certainly from a tolerability standpoint, ibrutinib has been very well tolerated. Now, some would argue, well, but we haven't really seen comparisons to our best therapies, our BRs, our FCRs, and that is true, except to say that those trials have been done. They've very recently completed our direct randomized trials, and so it'll be very helpful to see the results of those as well. Sometimes when we do clinical trials, the focus is all on the initial results, say one therapy versus another, who does better. There's different ways of measuring what better is, but one of the other advantages in many situations is really learning how patients do as they continue on a therapy or after they've received a therapy and are followed over time. We all want to know how patients do who receive FCR. And so, for example, recently there is a lot of data on long-term follow-up from FCR studies. How do patients do 10 years later? And that's definitely true with drugs like ibrutinib. So our very first trial in CLL, after the first-in-man trials, we're still following those patients. Those patients are still enrolled in those trials that began over 6 years ago. And those trials are invaluable in terms of not only learning whether patients still benefit, whether their disease is still controlled, but also how well it's tolerated. Can they stay on the therapy? And that's especially important because this is a therapy that we have dosed continuously. So the RESONATE-2 trial, for example, again, one could say, well, that's a comparison to chlorambucil. That doesn't really matter. Of course, it's going to show an efficacy advantage. I think the great advantage of that trial is going to be following that large group of patients who have received ibrutinib as initial therapy, both to answer the continued efficacy standpoint and also safety. So it's nice that we have the availability of continuing to monitor these patients in order to really educate ourselves and educate our colleagues in the community about what to expect longer term.